I don't know if Ann Moser needs an introduction. She's the reason we're all here, I guess. Uh, going going back many decades.
Do I have to turn it on?
No.
I think Stefan gave you a nice introduction to ALD newborn screening. So thank you for that. And I want to thank Elisa Seeger for providing me some updates and her comments on the slide presentation. And then she has a slide at the end, and she will tell you about what she's doing currently. So this is an update on ALD newborn screening. So the purpose of ALD newborn screening is to prevent the overt adrenal insufficiency, reduce the risk of childhood phenotype by lowering the very long-chain fatty acids in the body, improve prognosis of cerebral ALD by facilitating early stem cell and gene transplants, and to improve success of future therapies we hope are coming along. We identify at least 80% of the ALD heterozygotes, the females, and that will help provide family screening for male ALD relatives. And we also diagnose the peroxisome biogenesis disorders and other peroxisomal very long-chain fatty acid disorders where there may not be therapies. However, we think it very important to help with the diagnostic odyssey, provide genetic counseling and early supportive therapy for these disorders. So here's the minimum birth frequency of ALD in the United States. This was published back in 2001 by our group. And so if you look at the male population and the female population, the numbers are somewhat different. However, together, we predicted through family screening that it would be about 1 in 17,000. And similar results were obtained in calculations in France and Canada. So in 2004, my husband, Hugo, and I were at a newborn screening meeting at NIH. And he persuaded the newborn screeners to add ALD to the list of disorders to screen at birth. However, there was no test on the blood spots at that time. And we only had the plasma very long-chain fatty acid test. And obviously, the way newborn screening was done was on the whole blood spot, which we showed was not really a good vehicle for measuring very long-chain fatty acids, total lipid very long-chain fatty acids at the time. So it took us a while, and my husband recruited Walter Hubbard to help develop an assay for ALD newborn screening. And we went through a number of lipids that were in the blood spot that we knew had C26 fatty acid, which was the marker for ALD. However, most lipids did not show a good separation between controls and ALD. However, Walter Hubbard was measuring the lyso-PC in breath exudates from asthmatics. So he had this very, very sensitive assay. And so we looked at the C26 lysophosphatidylcholine in the blood spots, and we found a very good separation between ALD and controls. Then we took some money and gave it to Avanti Pololipids, and they synthesized this substrate. And then we validated pulling newborn blood spots from the states of California and the states of Michigan, where we knew that those two states saved their blood spots for many years. And we asked the families of known ALD patients if we could pull the blood spots. So we validated the assay for the newborn screening in 2009. And then in 2013, we completed a screening pilot of 5,000 newborns in Maryland, and we did not find one positive. So we thought perhaps the test was good because there were not many false positives, certainly. And then in December 2013, New York State added ALD to their newborn screening panel. And it took us a while to persuade the Secretary's Advisory Committee to add ALD to the recommended uniform screening panel, the RUSP, and that happened in 2015. So I just wanted to show you a picture of the C26 lyso-PC. This is the natural compound, and this is the compound with 4 deuteriums. This is what's called an internal standard. So it's a very sensitive assay. We measured in many different blood spots. Here are new normal from normals. That is, normals we determined had normal very long-chain fatty acids in plasma. Here are the newborn blood spots that we obtained initially before we started our big 5,000 pilot. And we presumed that they were all normal. Here are the 18 newborn blood spots from ALD patients that we pulled from California and Michigan. Here are postnatal ALD blood spots. And what you notice is that the mean is quite different postnatally. These are all ages, including, I think, one AMN who was 70 years old. So there's a wider range, and the mean is lower. So this marker, I believe, is higher at birth than if you take all the range of ages from the ALD patients, male patients that we had. And here are the female carriers in the blood spots. Again, they separate from controls. However, there are a couple of patients who are below. They're in the normal range. And this is the problem with markers for the women, which Stefan very nicely described. And here are the peroxisome biogenesis disorders. Again, they're postnatal, and they run a little bit higher than ALD. So the lyso-PC26 assay identifies ALD. It identifies the childhood cerebral phenotype, which occurs in about 35 to 40% of subjects. And it identifies the adult form, the male adult form, AMN, and Addison's disease only. And these individuals we follow because they have the biomarker for ALD. However, they have Addison's disease only. And some of these individuals are quite old, over 50, with no AMN. The test also identifies, I say, 80% of ALD heterozygotes. It may be higher. And the peroxisome biogenesis disorders, the Zellweger spectrum disorders, and the single enzyme defects of peroxisomal fatty acid oxidation. So many, many thanks to ALD newborn screening lobbying by the ALD family support groups. And without these lobbyists, I don't think ALD newborn screening would have passed the Secretary's Advisory Committee in the United States. So this is very, very important. And the lobbying in New York, Minnesota, New Jersey, Connecticut, Georgia, DC, Maryland, California, Texas, Illinois, Florida, Pennsylvania, Nebraska, and Massachusetts has resulted in legislative approval to add ALD newborn screening. And the lobbying continues in many other states. And here is the update. New York, thanks to Elisa Seeger and the Iden Jack Foundation, but Iden's Law in New York, started screening at the end of December 2013. Connecticut started in October 2015. California started in September 2016. However, they were legislated to go 6 months backlog to the time that the Secretary of Human Health signed ALD into the recommended screening panel. So they had a 6 months backlog, and you can imagine what that did for the newborn screening in California. That's a state with a very large birth rate. Minnesota and Pennsylvania added ALD to their newborn screening panels several months ago. Georgia recently implemented a pilot, and Washington, D.C. says they will start this fall. However, they haven't started yet. And you saw this map that was in Stefan's slides, and it's on the website, the Netherlands website, showing the 5 states in green that are currently doing the newborn screening, and those in red that will start screening soon. And the blue states are mobilizing, and I might say Alabama should be blue. They say that they're going to start in a year or so. I was in Alabama to give a talk a couple of months ago. So here is New York State, very, very successful at newborn screening. They've done 880,000 tests between December 30th, 2013 to the end of September 2017. Their first tier is the fast, about a minute test. High throughput, it's called. That's their first tier, and they screen for ALD, and they combine it with a screen for other lysosomal disorders, including Krabbe disease. And their positive for ALD is about 1.8%. So they take those 1,619, and Mark Morrissey's group does HPLC and MSMS using the marker for C26 lyso-PC, and they reduce that number to 80, which represents a 0.009% of the total. And then they take those 80 and they do the third tier test, which is to sequence the ABCD1 gene, all using that initial blood spot that was taken from the babies at birth, or 2 days within 2 days after birth. So they reduced this to 80, which is a number which can be managed. Still a very high number here. And they confirmed that 30 males had ABCD1 mutations. 27 females had ABCD1 mutations. So together, I calculated all ALDs as 1 in 15,439 births. Now, this is very close to what we predicted. They also found and confirmed other peroxisomal disorders, including two single enzyme defects, and the remainder are Zellweger spectrum disorders, so that's about 1 in 88,000 births. And the one Aicardi-Gouttières syndrome, which was confirmed by mutation. However, they have 12 where no mutation was found, so they still have some work to do here. So this is Connecticut. They do a two-tier screening. Their first tier is to do LCMSMS using negative ion, which is a very sensitive way of looking for the elevation of C26 lyso-PC. And as of, this is June, I'm a little out of date with Connecticut. They have screened, in June they had screened 61,000. They had 17 positives, 7 with second request, 5 normal on second sample analysis. False positive was 1, and they were pending 3. They confirmed 9 with ALD, 4 males and 5 females. And siblings, now this is an X-linked disorder, so these families go into genetic counseling, and there were siblings. There was 1 male and 1 female identified who were siblings of these babies. And there was 1 Zellweger spectrum disorder. So with a smaller number screened, you get a higher rate here. And it will take many years before Connecticut gets to the 880,000 that have been screened in New York. And also in Pennsylvania, I'm a little out of date too. This is July 15. Their ALD newborn screening started in April, and 35,500 were screened in the first tier test. Now they do the high throughput test that New York does, and they do the second tier, which is LCMSMS, just like New York. And so they drop the second tier numbers a little bit higher than New York. And then the third tier is ABCD1 mutation. So they had identified 2 males as of July 15th. However, I've been talking to several geneticists in Pennsylvania. They always call on our lab to do some testing. And I know of 2 female carriers also from Pennsylvania that were identified. Okay. So this is Minnesota. Lisa Seeger gave me the update. So this is as of October. They have screened 45,000. They've identified 5 males and 4 females. And these are all ABCD1 proven ALD, which gives a very high rate. In Minnesota, it's especially in the areas where these 2 of these individuals identified on newborn screening. 2 of these individuals lived in the farming area of Minnesota. They have very large families. And so from these 9 cases of infants found with ALD, they have already identified 24 additional family members with ALD. So this is the impact of an X-linked disorder on newborn screening, particularly in states where there are areas where there are very large families. And here's California, updated to August. They have already done 720,492. They're tier 1, which is a high throughput screening again, like New York. They have 2.7% positive. And then their LCMSMS, their tier 2, they've identified 158, which is a percentage. If you remember, New York had 0.009, and the California tier 2 is a little bit higher than, it's almost double what New York gets. And they have identified and proven 11 males and 19 females with pathogenic known ABCD1 mutation. And that incidence is 1 in 24,000, okay? They have 35 males and 38 females with variants of unknown significance, and that incidence is very high. And this is a complicated chart. So this is the ABCD1 sequencing result in 158 newborns with elevated tier 2 screening results in California. The known pathogenic, again, 11 boys, 19 girls. So this represents almost 7% and 12% of the total of the 158. Variants of unknown significance, they have 35 boys, 22%, girls, 38%, 24%. Now, known benign polymorphisms, they had 10 boys and 24 girls. So these were known to be ALD mutations that are not disease-causing. They're benign polymorphisms. And then no mutation, the boys were 10, girls 11. So no mutation in ABCD1. So the only number here which we can hang our hat on is the 1 in 24,000. So we noticed in our lab that we were getting a lot of samples from California during the same time period, and these were all newborns. And we said, what's going on? They're sending us samples of plasma for very long chain fatty acid assay. And we're probably the second lab to do this analysis, and they wanted to double check to see what our lab found for very long chain fatty acids. So we didn't get 158, we got 114 newborns during the same period. And we found abnormal very long chain fatty acids in 25 boys and 11 girls. Now these don't match really, and that's an incidence, if you use the 721,000 screened, that incidence is 1 in 20,000, okay? We found slight increases in 2 boys and 6 girls. Now, for the girls, maybe they're heterozygotes. We don't really know. But that added a little bit of percentage uptick here. But however, we found normal results in 30 boys and 40 girls. So these are not ALD as we know it. And these may be, we're not sure. But these are definite. But the abnormal also includes the Zellweger spectrum disorders. So this is just a guesstimate, because we do not get all the information. We just get a plasma sample, we get the date of birth, we get the date of sample, we get the sex. That's about it. We don't get anything more. So I just thought this was interesting to share. This is from California. So the current follow-up recommendations for ALD babies. For all ALD babies, that's males and females, genetic counseling for the family. That's number one. For the males only, assess adrenal function in the newborn period and every 6 months thereafter. Adrenal hormone replacement if found to be deficient. For the males only, follow with MRI every 6 months, and the date of start is still under consideration because in the newborn period, we've never found ALD cerebral earlier than 2 years of age. However, if the MRI is abnormal and progressively abnormal, refer for bone marrow transplantation if there's matched sibling donor, or umbilical cell transplant if matched, or if no match, refer for ABCD1 gene therapy. Okay, this is a little advertisement for the Moser Center for Leukodystrophies at Kennedy Krieger under the directorship of Ali Fatimi. And this is recommended for adults and children with ALD or any other neurological disorder. There is a large list of thank yous and acknowledgments. This is our team at Kennedy Krieger and Jerry Raymond, who's not, I should have changed that. He's now in Hershey, Pennsylvania. Walter Hubbard is retired, and these are all the different laboratories in New York State, California, Connecticut, Minnesota, the Mayo Clinic we work with, and here's the geneticist at Children's Hospital of Philadelphia. Chris Haynes at CDC is one of my heroes. He provides positive blood spots. He spikes blood spots with the C26 lyso-PC, and we use these to calibrate our instruments. So that's very important. And then Michael Gelb is continuing to identify new tests for leukodystrophies. And then all the funding disorders, funding agencies who supported ALD newborn screening. Thank you to all of you who are part of these family foundations. And then I wanted to show you a picture of an ALD family in Bolivia. My daughter and I, when we participated in Rare Disease Days in Cochabamba, Bolivia, last spring. And this woman, Irma Martinez, has a foundation who supports all rare diseases and with a particular interest in ALD because ALD is in her family. So I just wanted to share their picture with all of you. So Lisa?
Thank you, Anne, for your dedication to ALD. None of this would be possible without you. So to add to Anne's presentation, obviously I'm obsessed with newborn screening. So I spend a lot of my time speaking in different states, and I've spoken probably in about 12 states to date. I just think it's not acceptable in this country that we have to go through 50 different states in order to have ALD added. So imagine that you have a little boy tomorrow and you don't live in one of the 5 states that are testing. Your baby doesn't have the same chance at a normal, healthy life. I don't believe that a child's life should depend on their zip code. So I continue to fight for ALD. back in 2015, I started to research into a federal mandate. So instead of going state by state, we could actually have the federal government, once it's been added to the RUSP, which it has, um, give a mandate to the state. So we don't have to go through this process 50 different times. So during Rare Disease Week of 2016, I was able to have 2 federal bills introduced, Senator Schumer and Congresswoman Clark in the House. Um, Unfortunately, we didn't make it too far. I mean, at that time, Senator Schumer was pretty powerful, but as we know with the election that happened later in the year, um, my hope for him to be Senate Majority Leader didn't really work out. So we didn't make it to the floor for a vote. And I took a break from lobbying in DC for probably about a year now, but I've started the process again, and I spent I spent Monday and Tuesday of this week on the Hill lobbying and trying to get some sponsorship for the bills, specifically Republican sponsorship. So the issue with the bills while I was lobbying DC and trying to get co-sponsors, which I didn't realize, and it was a learning experience for me, is that Republicans do not like the word mandate. So we have adjusted the bill language to be discretionary. It does still have funding attached, which is very important. As I said, speaking in the different states, what I realize is the primary issue is the funding. Although Illinois has a law to implement ALD, they don't have the funding to move forward. So I thought that that was very important. So I will be back in DC during Rare Disease Week, and I just want to extend the invitation to anyone that wants to come and help lobby and move this forward would be great. And then I'd just like to talk about the standards of care, going back to what Dr. Eichler talked about earlier today. Once a baby is diagnosed, I felt like I met some of the families in New York, and I was a little troubled that they weren't getting the care that they needed. So imagine getting the diagnosis, but now you're not getting the follow-up that you need to actually have the best outcome. So this past January was my first standards of care meeting. And this coming January, 2018, we'll have our second annual meeting. And it will just basically go over the parent experience, what their lives are like after the diagnosis, going through the endocrine piece, which I felt was very important. There was a lack of information on what to do on that. Obviously, neurology and having all the neurologists together, nutrition, reproductive options, and so on. So hopefully this will continue the conversation. And as we add more states to the mix, we'll be able to share that with the other states and give them the information they need to actually give these babies the best care that they need. And then finally, I just want to share a picture of some of the families that were diagnosed through newborn screening. And this is a reason why I continue to do what I do. I didn't know if I'd ever be able to meet one. But I know that their lives will be very different because of it. So thank you.
Hard words to follow. Very powerful, Lisa and Anne. I do want to give people a chance to ask questions, and also Stefan before we go into lunch. Kendrick?
So this is really transformative. This is fantastic to see all these numbers and to know that these children's lives are going to be completely changed. It's really amazing. So I have a question about the testing. So the parents receive information about the positive result on the VLCFA screen. Do they receive that after the Tier 1 or the Tier 2 test?
They receive it after the Tier 2 test.
Florian, you should talk about this. Massachusetts will begin testing early next year but the Massachusetts lab at University of Massachusetts tests for the other New England states other than Connecticut. And usually the other states follow. So Massachusetts is starting with 4 diseases, including ALD, and then the other states, other than Connecticut, will likely follow. Florian, you can add more. You're their advisor.
I confirm. So.
Yes, we knew about it because we've been sharing blood spots with state lab in Massachusetts.
Yeah. So there are obviously these questions with these patients who have variants of unknown significance. And I was wondering what people thought the clinical path for them should be, you know, in the absence of the thorough investigation that Stefan described. Should they be getting MRIs, or are there thoughts around that?
Well, I think the first thing is they have to have the plasma very long chain fatty acid test. And if that's positive, then I think there is a consensus that that mutation is probably disease causing, and they should be followed. Okay. And if the test is completely negative, the plasma very long chain fatty acid test is completely normal, I would say that it's probably a benign polymorphism. It's the gray area that we're having trouble with.
I think now that we have Aiden Jack Seeger's foundation, it gives us somewhere to look for information. Because when my son got diagnosed, I took him in for MRI. I think it was an MRI, CAT scan, because my doctor thought he had a stroke from his neurological visit that day. And turned out he had ALD, X-linked. And 2 weeks later, Steve literally stopped walking. So I didn't know where to turn to. Of course, I called Kennedy Krieger, and the lady says, "What's Steve doing?" I said, "Well, he can't walk without assistance." So I was calling for the oil. And she goes, "It's not going to work." And then, Steve went down in 3 months. Everything was gone. I just wish there was a way, like now that we have, because it's like you don't know where to go. The pediatrician kind of like just sticks you with a neurologist. The neurologist gives you the diagnosis, and then you're like on your own. I had to figure out, what do I do next? And that's the hardest thing, to figure out what to do next. And then I finally got to speak to somebody, I think it's stuff. I'm not sure which organization, and I had to get an endocrine doctor, which I think Elisa now can educate a lot of people with. But it was just like, you don't know what to do. Like, after you get the diagnosis, where do you turn to?
Well, I think Hunter's Hope organization has made it one of
Hunter's
their
Hope
mandates to establish centers of excellence for following leukodystrophy patients, including ALD.
I think at the time it wasn't that popular because Stevie was born
Right,
in 99.
and it's my hope, and I'm sure it's the hope of all these ALD lobbyists, that there will be centers in various areas of the country so that we'll be experts in treatment of leukodystrophies, including ALD, so that parents, their primary care physician can refer to these centers of excellence. This is what's needed for the future.
Most definitely, because it's been just like
And
now
so you don't
more
have to fly away to come to Kennedy Krieger and have to wait for a year for an appointment. This is crazy.
I never made it to Kennedy Krieger. I just been dealing with everything in New York, and now I moved to Connecticut.
I know Ali fits in people who need to be seen more rapidly at Kennedy Krieger, but
I don't think that
we
my
need,
situation, I don't think the outcome was going to be
we
any
need
different.
centers all over the country.
I have a couple questions. Our child was one of the first newborns diagnosed at UCLA. And with our initial conversation with the geneticist, it seemed he had one kind of outlook on it, and then we spoke to him about 3 months later, and he was actually shocked by the amount of cases that had come in. I think it was partly from the backlog. So one question is the data going to change because of the newborn screening? Are you seeing any difference in the data because there's so much more coming in?
No, I think in this, if you look at the New York figures, I think we can believe that. It's almost, well, it's 880,000, and the incidence of ALD is about the same as we predicted through family screening. Maybe a little bit more common, but not huge difference.
And then as far as the screening number,
I wanted to know what the marker was for slightly elevated versus completely abnormal, what the number was.
Well, it varies from lab to lab. In our lab, we measure the elevated, we measure the C26 level. We look at the ratio of other fatty acids, the C24 to C22 ratio, the C26 to 22 ratio. That's done in plasma. And then, as Stefan described, if the results are borderline, not classically abnormal for males with ALD, then we would like to study the C26 fatty acid and the C16 fatty acid in cultured fibroblasts. And we do the oxidation measurements. And we also look at the presence or absence of the ALD protein in fibroblasts.
Our son has the unknown variant. And when I looked on that chart online that you developed, it's on, the change in the gene is on there, but it's from an unpublished study. And it says probably pathogenic. So I wondered where that came from as well. I think only one other person maybe had that change in the gene.
Yeah, probably. Yeah, we should look at it. Probably. Yeah. If there is a reference, then it should be a reference to a paper. It can also be a reference to any of the 13 diagnostic laboratories that donate their information. So we can look at it. Yeah.
Would ours be on there already? Do they?
No.
Okay.
There, I think there are only 2 from Minnesota that were shared. There is no way, there is nothing set up for sharing information. That's why I again said sharing is important, but some things don't come natural. So, of course, there are issues involved, and I don't know. So the hope is that eventually it will be shared because it helps. If there was not be NS1, what would be say, okay, this has been identified by 5 ALD patients, then it would not be a fuss. Then it would be much more clearer. So like I said, we need to get all that information.
Yes, because it's in my family.
Yeah,
There's
yes.
a lot of us
yeah,
so far.
That's exactly what's underneath that quest, for a request for sharing is exactly what you mentioned. What you mean.
So I had a quick suggestion. I think that the newborn screening is great. I'm back here. But I think one of the things we need to do with that is create a registry for all these patients. I'm not aware of that you have one, and I think it would be super valuable. We have maintain contact with all these patients that test positive, and then track the disease progression depending on the genomic profile of those patients. So we get a better history of when to treat and when to intervene in therapy. So I don't know if anybody's thought about doing that, but it seems like that's the next step beyond the screening.
Well, I think the registries need to be established voluntarily. That is, they would come to ALD Connect and be put into the registry. That's probably the best vehicle that has already been established by Alex Sherman.
Perhaps we need to spread the information wrong.
Yes, I think that...
information to, sorry, Alex Sherman, Mass General. So perhaps what we could do is to spread the information that such a registry exists, and then work with those centers to give those pamphlets, whatever we come up with, or cheat sheets, whatever we come up with, to the patient or parents rather.
I have a question idea. I'm Patty Mussolino from MGH, work with Dr. Eichler. I'm also a neurologist and I work in rare disorders and ALD. I think there is a bigger and bigger, more available platform of remote consultation and patient registry and education materials. ALD Connect has already put a lot of this education materials and their seminars, but I think in terms of consultation, and this comes from the question of how we are gonna serve all these patients that are being newly diagnosed, it might be worth start thinking about a remote platform that is served by the experts. I don't think you're gonna be able to train enough. There is not enough child neurologists to start. There is not enough geneticists. There is not enough genetic counselors. But maybe we have resources that we can centralize on a remote platform. And from that, patients can tap on and have a much more active and probably much more accessible for families that even have children affected, where traveling is also not a possibility or is very limiting for a lot of these patients. I think there are limitations in terms of licenses. There are limitations. There are always challenges, but I think ALD Connect has already made a little bit of this. We have used remote platform for recruiting for the clinical trials. I think we have to start exploring and lobbying and advocating and funding this remote platform for clinical care. The resources are scant, but they can be made available probably by just extending the video and remote capabilities that there exist already.
Say that our family was diagnosed 2 years ago, and we were lucky enough to meet Dr. Fatimi and team. We're very grateful to be here. All 3 of our kids now know what they have and how they can deal with it for the rest of their lives. Thank you.
I have a quick question. If you live in a state that does not test, but you know it runs in your family, they will run that test through if you ask for it, correct?
You can send it to our laboratory.
Your physician or that individual's physician can order the very long-chain fatty acid testing. There's, it's done now at LabCorp, Quest, our lab. There's multiple, labs across the country, and it's usually it's a pretty cheap test. It's about $180. So even if insurance doesn't pay, which is highly unlikely because it's not a genetic test, it's just a metabolic study. It's doable. So.
We do the test on the blood spot obtained in the newborn period for those families who want their newborns tested. And that test is $100 in our lab. And the Mayo Clinic also does it.
The difference that you saw in the tests run at California versus in your lab, was that because of the different assays that you were using?
Plasma very long chain fatty acid assay. And in California, the results were on the newborn blood spots.
So because this is being used to grade this is being used to tell the patients if they have the disease or not, is there a way that you can run the same kind of test in the different states?
Yes, I know there are many labs that do the plasma very long chain fatty acid assay. And I have to again mention that if you saw my blood spot results of using the lyso-PC26 as a marker, it appears to be higher in the newborn period. That is 1 or 2 days after birth. And then it probably, we haven't done studies following it. We need volunteers to draw blood from, say, a baby boy identified with the biochemical marker for ALD at birth, and then follow it maybe every 2 months or so and see if it goes, if it normalizes, or if It will still stay in the ALD range, but it won't be as high as in the newborn range. And these are studies that are very difficult to do for IRB or institutional review. We have to get permission to do that kind of a study. But it should be done, I think. Don't you agree, Stefan?
Yeah, I agree, but I think it's next to IRB, it's going to be a challenge to ask a family to participate in a study like that.
Yeah.
It's yeah. But
you have to piggyback on blood draws that are going to be done anyway.
Absolutely.
Yeah. Right.
Significance. How are you planning to monitor those patients who have somewhat elevated levels of VLCFA and then their genetic mutation is of unknown significance? Would they be monitored every 6 months with MRI, or what is, because we don't really know, they can still get the disease?
That's a very good question, and I think that there's not a good answer to this. First of all, it probably depends from state to state, because different states probably have different protocols running, and it may also from center to center. And that's exactly what Elisa is now organizing, is that we have to come together to generate these protocols, because they don't exist. And as an example, Jerry Emmett, he showed MRIs in New York from a child of 6 months, but the brain is not fully formed yet. So the brain MRI is informative, is inconclusive. It's so this is new territory that's unfortunately that has to be explored.
So I'm happy that we're actually with this discussion coming to exactly the same point where our late night board of directors discussion was heading, which is we've finally, thanks to the help of Anne and Elisa and many others, gotten to this point, this mountaintop of newborn screening. But lo and behold, it is opening up all sorts of new challenges, and particularly the need for now knowing how to track, monitor, engage. And I think this is exactly what our mission of ALD Connect is, and so trying to tie back here. I think a lot of the sentiments that people are bringing up here, since we're moving.